last speaker, Dr. Noha Tarek, lecturer of internal medicine, diabetes and endocrinology, قصر العيني faculty of medicine. يعني برضو MD. أنا يعني دكتورة نوها هتتكلم عن الميتفورمين توكسيستي. مهما هتقولي عن الميتفورمين مش هيتشاف. اتفضلي يا دكتور.
مساء الخير على حضراتكم. Our presentation is about a case report for metformin toxicity. We have an 18-year-old female patient presented to the emergency department 3 hours after a suicidal attempt with 30 grams of metformin, severely agitated, confused with severe abdominal pain associated with persistent vomiting. Her examination revealed tachycardia where her pulse was 120. The patient was choked with blood pressure 80/60. Her temperature was normal. Respiratory rate was 28. Otherwise, her examination was totally free. Her arterial blood gases on admission showed a profound lactic acidosis. Her pH was 6.8, PCO2 27, and bicarbonate 4.2 with serum lactate more than 15 millimole per liter. Investigations done on admission revealed mild normocytic normochromic anemia with mild thrombocytopenia, and TLC was elevated with shift to the left. Her coagulation profile was within normal. She had mild hypokalemia where potassium was 3.1, acute kidney injury, her creatinine was 1.8 and urea 59. Also, she had mild elevation of LDH, CRP, and serum amylase less than 1-fold. The patient admitted to the ICU and she was shocked. She was resuscitated by IV fluids in the form of Ringer acetate, and the patient was started on noradrenaline with no response, so adrenaline was added. She had severe lactic acidosis and received sodium bicarbonate 200 milli infusion. Lactic acidosis was persistent even after the sodium bicarbonate, and so she received 1 hemodialysis session after nephrology consultation. These are the serial VBGs. After receiving sodium bicarb, her pH reached 7, bicarb reached 8.6, but the lactate was still high. After hemodialysis, her pH was 7.28, bicarbonate reached 9.3, and serum lactate dropped to 6.6. On the next day, the patient was off adrenaline, but withdrawal of noradrenaline was difficult, so dobutamine infusion was added, supported by the data detected in echocardiography. Her echocardiography revealed ejection fraction 20%, regional wall motion abnormality in the form of akinetic whole septum, hypokinetic other whole segments sparing the apical segments. She had moderate secondary mitral regurg, impaired right ventricular systolic function. Her cardiac enzymes were negative. On day 3, the patient developed 1 attack of convulsions, generalized tonic seizures followed by post-ictal confusion. Neurology consultation was done. Her CT brain was normal. The patient was diagnosed as systemic seizures, with the possible causes include systemic infection, metabolic acidosis, or the electrolyte abnormalities. She was started on levetiracetam 500 mg twice daily, and elective MRI and EEG were recommended. On day 4, the patient developed 1 attack of melena. Intravenous proton pump inhibitor infusion was initiated and melena stopped with no hemoglobin drop. On day 5, the follow-up echocardiography showed ejection fraction 60%, normal left ventricular dimensions with normal overall contractility. Noradrenaline and dobutamine were withdrawn successfully with normalization of her blood pressure and intact peripheral pulsations. And all her laboratories, including VBG, normalized. So we are talking about a case of metformin toxicity due to suicidal attempt. Metformin toxicity is considered rare condition but serious, associated with high morbidity and mortality. There is no clear definition for metformin toxicity. It was supposed that in acute overdoses, the lethal doses greater than 5 grams in adults and greater than 100 milligrams per kg in pediatrics. Some define metformin toxicity as lactate greater than 5 millimole with pH less than 7.35 in association with metformin exposure. The most serious complication of metformin toxicity is lactic acidosis, and there is a complex relation between metformin and lactic acidosis. It may be metformin-induced lactic acidosis, or metformin-associated lactic acidosis, or metformin-unrelated lactic acidosis. When a patient presents with hyperlactatemia and he's on metformin, we should ask if the patient is actually taking metformin or not. If not, so it's not related to metformin. If yes, we should ask about the dose of metformin. Did the patient take a large dose of metformin or not? If yes, so it's most probably metformin-induced lactic acidosis. If no, it's metformin-associated lactic acidosis, where the patient is receiving a regular dose of metformin with another stressors as chronic renal failure, sepsis, or surgery. And metformin-associated lactic acidosis carries a higher mortality than the metformin-induced lactic acidosis. How to manage metformin toxicity diagnosis? As we said before, usually there is a history of metformin intake with pH less than 7.35 and serum lactate more than 5 millimole per liter. We start supportive management in the form of intravenous fluids, and intravenous sodium bicarbonate is indicated when pH is less than 7.2, PCO2 less than 45, and bicarbonate less than 20. Treatment of the concomitant conditions as diabetic ketoacidosis or if there is renal impairment. If the patient has cardiorespiratory collapse, so we start vasopressors. Up to the patient may require intubation, reaching to ECMO support. Kidney replacement therapy for cases with acute kidney injury. Then, if these supportive measures failed, we start extracorporeal removal of metformin if pH persistently less than 7 or lactate more than 20. Or there is decrease in the level of consciousness, kidney failure, or liver failure. We stop extracorporeal removal when the blood lactate drops less than 3, pH more than 7.35. Fortunately, our patient was returned her lactate level after the supportive management. And this is a meta-analysis of the case reports that was published in 2022, showing 246 patients with metformin toxicity. 20% of them showed mortality, 70% of them was on regular metformin, while only 30% received acute intoxication of metformin. Our take-home message: although metformin toxicity is uncommon, it does occur with enough frequency and significant morbidity and mortality. Metformin toxicity exists as metformin-induced or metformin-associated lactic acidosis. Metformin-induced lactic acidosis is associated with acute overdoses, while metformin-associated is related to the effect of normal or elevated metformin concentration in the presence of a secondary stressor. Metformin-associated lactic acidosis has a higher morbidity and mortality compared to the metformin-induced lactic acidosis. Treatment for both conditions is supportive, including intravenous fluids and vasopressor support, and often requires hemodialysis. These are our references, and thank you.
حضرتك يا فندم قلتي ان الميتفورمين توكسيستي يا اما ميتفورمين انديوزد لاكتيك اسيدوزس
Yes.
يا اما اديناها لحد عنده لاكتيك اسيدوزس.
Metformin-associated lactic acidosis ده اللي هو patient regularly on metformin بس في other stressor. يعني patient developed kidney failure may develop lactic acidosis due to, and metformin will be a contributor in the process. أو patient داخل surgery أو عنده sepsis for some cause فالpatient بيدخل في lactic acidosis بسبب combined factors.
حضرتك اليوجوال او النورمال ثيرابيوتيك دوز للميتفورمين قد ايه؟
Up to 2 grams per day.
لغايه 3 كمان.
تمام.
هقول لك بقى خبر. انا بمارس الطب بقالي 50 سنه ممارسه. ما شفتش حاله. وكل اساتذتي الله يرحمهم كان ده دايما الكومنت بتاعهم في اللقاءات. اي ما حد يجيب سيره اللاكتيك اسيدوزس يروح الدكتور احمد علي الجارم الله يرحمه يقوم ويقول 60 سنة ممارسة، هو فعلا 60 سنة ممارسة أو أكتر، وما شافش حالة لاكتيك أسيدوزس. هو جايز الواحد طبعا يعني احنا عارفين ان احنا مش هنديه لحد عنده رينال فيلير
بالظبط.
ولا حد عنده هيباتيك فيلير، يس. لكن هل الناس النورمال انديكيشنز لما بنديه في منه خوف؟ I think no.
No.
Agree؟
Yes, I agree. البيشنت بتاعتنا كانت suicidal attempt.
ايوه يا فندم.
فعشان
لا
كده
هي غالبا بلعت حاجات تانية.
هي قالت ان هي بلعت 30 بلعت علبه من الميتفورمين ال 500
ما شاء
كانت
الله.
بتاعت والدها.
ما شاء الله ما شاء الله، ربنا يهديها. اي اسئله للدكتوره نوها؟ اتفضلي يا فندم.
عليكم السلام يا دكتور. هي اصلا مش بتاخد ميتفورمين يا دكتور، شي از توتالي فري.
ايوه كيس ستادي. ايوه
احنا كاتبين ميتفورمين توكسيستي كيس رابورت بس تمام يا دكتور.
الريسيرش اللي حضرتك عرضتيه دوت كان بيتكلم على ميتا اناليسيز لكام حاله؟
246
246 لاكتيك اسيدوز.
246 بس all over the world ومتجمعين over اكتر من 10 سنين.
كده معقول. بعدين كنت هزعل قوي.
لا هي 246 all over the world.
تمام. حد عايز منها حاجه تانية؟ طيب احنا ان شاء الله متشكر يا فندم. احنا ان شاء الله بكره عندنا 11:15 جلسه هنا على هوت توبيك اللي هو الجات مايكروبيوتا في الديابيتس والنفلد باثوجينيسيس and the approach for treatment. الجات مايكروبيوتا بتاخد الجو كله دلوقتي، فنتعشى ونشوفكم بكره. اعتقد هيبقى لقاء ظريف جدا. انا متشكر جدا لحضراتكم. اتفضلوا يا فندم.